Okay, so I'm Tianyi Huang. I'm an assistant professor of medicine at Harvard Medical School and associate epidemiologist from Brigham and Women's Hospital. So actually, I can get into the sleep world only a few years ago. So during my postdoctoral research, I can shift my research focus from cancer epidemiology to the epidemiology of sleep and sleep disorders. And I really interested in this area. And also I feel there is substantial less work in sleep compared to other areas, even other lifestyle like diet and physical activity. So I think there's a lot of things to explore in this area. So today my talk is will focus on the role of inflammation and the insulin resistance in the development of obstructive sleep apnea. So this is the work directly supported by my KO1 award. So over the past 2 decades, there have been numerous studies that's trying to understand the mechanism linking OSA to increased cardiometabolic disease. So I think this study have shown that OSA can directly result in intermittent hypoxia, sympathetic hyperactivity, and sleep fragmentation. And these alterations can lead to inflammation and insulin resistance, which are 2 key drivers for cardiometabolic disease. And also now there's very, I think, established evidence suggesting that inflammation and insulin resistance are 2 closely related pathways that they can promote each other, and they can work interactively to lead to chronic diseases. So as you can see, most of the prior studies, they have predominantly focused on one direction of this association, which is sleep apnea that leads to inflammation and insulin resistance. And what remains unclear, and also there's very little evidence, is whether inflammation and insulin resistance can predispose individuals to increased risk of sleep apnea. So this is kind of my focus of research. So it's until very recently, there has been some review and also hypothesis regarding a bidirectional association between sleep apnea and type 2 diabetes. So I think in this review article, the authors propose a framework in which systemic inflammation and insulin resistance, as well as some other related biological alterations like oxidative stress, can induce glucose intolerance and lead to type 2 diabetes. And then they can, for example, the diabetic neuropathy, it can damage the peripheral nerves and lead to increased upper way collapsibility, and then resulting obstructive sleep apnea. And also people with diabetes, they tend to have ventilatory instability that can can lead to central sleep apnea. But based on this review, we can clearly see in their citation, there are substantially more evidence supporting sleep apnea to diabetes versus diabetes to sleep apnea. So I think my work is just trying to examine more evidence, see whether inflammation and insulin resistance can be predisposing risk factors for sleep apnea. So in this talk, I will first briefly review some experimental evidence for why insulin resistance and inflammation can lead to sleep apnea. And then I will primarily focus on some epidemiologic evidence, I think primarily prospective studies, including the work that I have done or I'm currently doing to show that inflammation and insulin resistance can be risk factors for sleep apnea. And finally, I also talk about some clinical implications from these findings. So there actually are not that many experimental studies that show examine inflammation or insulin resistance in the pathogenesis of sleep apnea. But and also most of those studies are very old. They are back in the early like 2000s. But I think the good thing is that these studies, I think they provide very direct and compelling evidence suggesting that inflammation can promote sleep apnea occurrence. So, for example, there are studies that show that inflammation have direct impact on breathing. Inflammation can enlarge the soft tissues and then reduce the airway patency. It can also weaken upper airway muscle that lead to airway collapsibility. And also increased inflammation, especially the local inflammation, can impair neuromuscular control of breathing and also lead to sleep apnea. In addition to the direct impact on breathing, inflammation also has an independent impact on sleep. So now there is actually more evidence on this part is that inflammation regulates wake sleep cycles, and also inflammation induce sleep propensity and also sleepiness, which means that inflammation may be more strongly related to those symptomatic sleep apnea or more severe sleep apnea. Here is the study that back in 2004. So this study compare the different inflammatory cell count between people with OSA versus controls. So like the y-axis is the ratio of different inflammatory cells between OSA cases and controls. And the upper, like the figure in the upper is a comparison in the upper airway mucosa, and the figure below is the comparison in upper airway muscle. So you can clearly see that like different types of inflammatory cell are overexpressed or much higher among people with sleep apnea compared to those without. I think this provides direct evidence that at least local inflammation is a problem in people with sleep apnea. And similarly, there are some evidence supporting that the insulin resistance may be also important in sleep apnea pathogenesis. And again, I think the evidence is kind of old. I think those studies are relatively old and there are not many studies. So first, I think the first piece of evidence I think came from 2001, suggesting that diabetes and insulin resistance can lead to abnormal ventilatory responses to hypoxia and hypercapnia. And also there are some animal studies found that these abnormal ventilatory responses can be reversed by enhancing insulin sensitivity, for example, by injecting or administering like insulin or metformin to those like experimental mice. And in some like clinical samples, they also find that insulin resistance was positively correlated with measure of pharyngeal collapsibility, suggesting that insulin resistance may promote sleep apnea onset by increasing upper airway collapsibility. And so this is a mice study in which they, I think they have three group of experimental mice. So like the S group is the mice where the mice receiving standard diet, and the HF group include the mice receiving a high fat diet, and the MHF group is the group that receives a high fat diet concurrently with metformin. So you can see after like 3 weeks of treatment, there is substantial increase in the apnea events among the group receiving high fat diet. But for the group but for the group that receive both metformin and high fat diet, there's no, I think there's no increase in the apnea events. And I think the apnea incidence is very comparable to the group receiving standard diet. This suggests that like the high-fat diet can induce sleep apnea incidence, and potentially the metformin can contradict this effect. And further, I think this study add metformin to all these 3 group of mice after the 3 weeks of treatment. And interestingly, at the 4 weeks, they observe that even in the high-fat diet, even in the high-fat diet group, I think the increased apnea events was reversed after adding metformin to their diet. So I think this study provides like strong evidence that like insulin resistance may be a causal factors for sleep apnea. So then regarding the epidemiologic evidence, I think most existing evidence come from genetic studies. So there are prior like genetic studies have linking sleep apnea or sleep apnea related traits to genetic polymorphism. So in some earlier studies, so those studies are mostly candidate genetic studies, they found that polymorphisms in CRP gene, in prostaglandin receptor gene, and also in TNF-alpha gene are associated with sleep apnea or sleep apnea diagnosis. And more recently, in those genome-wide associated study, I think some top hits are also involved in inflammatory related pathways. For example, in this, I think in this 2016 GWAS study that's trying to find genetic loci for AHI, they found, I think one of the top hits is in the GPR83 gene, which encoding the G protein coupled receptor, and this receptor is known to play an important role to modulate inflammation and inflammatory responses. And a more recent GWAS that's actually, I think they examine the genetic loci with overnight oxygen desaturation burden. And I think very interestingly, I think the top hit for this sleep apnea trait is also involved in inflammation. So those top hits are the loci in the genes of the NLRP3 inflammasome. And we know that this one is also an important player in inflammatory responses. But other than these genetic studies, there are actually very few prospective studies kind of elucidating why like inflammation and insulin resistance may be related to sleep apnea. So, so next I'll talk about primarily my work in 4 US cohorts that's trying to kind of investigate these questions. So I think the first 3 cohorts I used are 3 Harvard-based cohorts. So the Nurses Health Study, Nurses Health Study 2, and the Health Professional Follow-up Study. So all these 3 studies are large, ongoing prospective studies of US men and women. So the Nurses Health Study started in 1976, enrolling more than 120,000 female nurses. And every 2 years, like we sent biannual follow-up questionnaires to update their lifestyle factors, their disease diagnosis, medication use, and many other health-related information. And also, these participants reported whether they have clinically diagnosed sleep apnea on those follow-up questionnaires. And similarly, Nurses Health Study 2 is a sister study of Nurses Health Study. So it started in 1989 and among a younger generation of nurses. And it had a similar study design, which included biannual follow-up using questionnaire. And also we ask people to report whether they have clinically diagnosed sleep apnea on the follow-up questionnaires. And these 2 cohorts are all female cohorts. So to complement kind of the two cohorts, we also have all-male cohort, the health professional follow-up study, which was initiated in 1986 among more than 50,000 male health professionals. And also this study had similar study design with like biannual follow-up and also with self-reported sleep apnea data. So I think one problem you can see from these three cohorts is that we only have a self-reported sleep apnea diagnosis, although the sample size are very large and also is encompassing a large age range and also include both men and women. So so just to can complement those self-reported sleep apnea, I also did my analysis in the multi-ethnic study of atherosclerosis, so a MESA study. So this is a smaller community-based study among about like 6,800 participants. So these participants were enrolled around 2,000 from 6 US cities and includes Caucasians, Asian Americans, African Americans, and Hispanics. And at exam 5, we conducted a sleep ancillary study in the cohort. I think more than 2,000 participants completed this sleep study, and the sleep study included 1 night polysomnography at home and also a 6-day antigraphy study. So my work primarily using data from these 4 cohorts. So these 4 cohorts, I think they complement each other, where I think the first 3 Harvard cohorts provide large sample size, although the sleep apnea is not very accurately characterized. But in MESA, although the sample size is more limited, but it has very detailed phenotyped sleep apnea. I think another challenge for me to study sleep apnea in the Harvard cohort is that although we have the self-reported OSA diagnosis in our cohort, no investigator can use those data before. So I'm the first one to study sleep apnea in this cohort. So the first study I did is a validation study of those self-reported sleep apnea. So overall, there were more than 9,000 incident self-reported sleep apnea diagnosis over 10 to 18 years of follow-up in our cohort. So because there are so many sleep apnea, self-reported sleep apnea diagnosis, so I did a pilot validation study in which I randomly selected 108 participants who self-reported they have sleep apnea, and I requested their medical record. And then I reviewed medical record and confirmed whether they have a sleep apnea or not. I think the results are very encouraging in that all these self-reported cases are confirmed to have sleep apnea. So you can see almost 90% of these self-reported cases have moderate to severe sleep apnea, and 92% of those cases were diagnosed by in-lab polysomnography. And I think many people, they have their diagnosis by 2 or more methods. And also 98% of those cases are obstructive sleep apnea. So I think these pilot results suggest that self-reported sleep apnea are highly accurate among US health professionals. And also these self-reported cases reliably capture moderate to severe sleep apnea. And I think this pilot study can form the basis for my other analysis. And so then based on the validation study and also motivated by the review, I just mentioned that I think which review the bi-directional association between sleep apnea and diabetes. So I think the first project I did in our cohort is I examined the bi-directional association between sleep apnea and type 2 diabetes in those 3 Harvard cohorts. So I think, as I mentioned in the review, most of the, I think the evidence that provide experimental evidence, and also many of the like the framework are based on hypothesis. So I think this is the first study providing evidence for the bidirectional association. So first, we confirm, like from the 3 cohorts, that people with sleep apnea, they have higher risk of developing diabetes. And we observe a similar association in men and women. So you can see for both men and women, those with sleep apnea, they had almost double the risk, or have almost double the risk of developing diabetes. And conversely, when we look at the other direction of association, we also observe that people with diabetes had increased risk of sleep apnea. Although the association are also like significant in both men and women, we found that the association is even stronger in women than in men. So you can see in men, the increased risk of sleep apnea is about 30%, but in women, the increased risk is about 65%. So when we further look at the association, so which is risk of developing sleep apnea based on diabetes status, when we further look at the diabetes status by diabetes treatment, we found that people with diabetes receiving insulin therapy, these people have substantially higher risk of developing sleep apnea. So this suggests that insulin resistance or like severe or even longer duration of diabetes may put people at particularly higher risk of sleep apnea. But still, we don't know whether it's hyperglycemia or insulin resistance play a more important role for this association. And then we pull the biomarker data from the 4 cohorts, so including MESA, to look at the association between inflammation and sleep apnea risk. So we use the C-reactive protein as a non-specific inflammatory biomarker for systemic inflammation. And we show that, I think we can, so here I show the results from individual cohort as well as from the pooled analysis. So I think we can focus on the pooled results. So you can see like in model 1, in which we adjusted for like many inflammation-related factors as well as like sleep apnea risk factors. We see a strong positive association between C-reactive protein and sleep apnea risk. And in model 2, when we first adjusting for continuous BMI, we observed that the association was substantially attenuated, but still we observe a moderate positive association between baseline C-reactive protein and the risk of developing sleep apnea during decades of follow-up. And also, as I just described, based on those experimental study, inflammation may be particularly relevant for sleep apnea with concurrent daytime sleepiness, or inflammation may promote sleep apnea occurrence by increasing airway collapsibility. So I did another analysis in which we look at whether the association between C-reactive protein and sleep apnea differed by like the sleep apnea subtypes. And interestingly, we see that we see the CRP was more strongly associated with sleep apnea with concurrent daytime sleepiness compared to those without daytime sleepiness. And also we observe that the association is statistically stronger for sleep apnea with high airway collapsibility versus sleep apnea with lower collapsibility. So I think these results suggest that can confirm those experimental evidence in the population-based study that like the inflammation may promote sleep apnea by increasing airway collapsibility and also by increasing sleepiness. And we also did some subgroup analysis for the association between CRP and sleep apnea. We found that the association were stronger in younger participants versus older participants, and the association is stronger in people with normal BMI versus people with overweight or obesity. And also the association was stronger in premenopausal women versus postmenopausal women. So interestingly, we know that older age, overweight, obesity, and postmenopausal status are strong risk factors for sleep apnea, but we observe that the association with inflammation actually are stronger in their counterparts. So they suggest that maybe inflammation is a more important risk factor among people without those established risk factors. Or it's also possible, it's just that the association is more easy to be observed among those people without those established risk factors. I think one problem with the biomarker analysis using C-reactive protein is that it's an observational association, and the association can be confounded by many factors that we cannot adjust for in the model. So the next analysis I look at is using the genetic approaches that try to provide some causal evidence. So there are some large GWAS that identified 58 SNPs associated with C-reactive protein at the genome-wide significant level, and 51 of those SNPs are available in our data set. So based on these 51 SNPs, I created a weighted polygenetic risk score for CRP, so that one unit increase in this polygenic risk score corresponds to one more risk allele in CRP, one more a CRP related, one more increase in the risk alleles. And also we find that this CRP genetic risk score explains about 5% of the variance in circulating CRP levels. So this is consistent with prior reports suggesting that this genetic instrument is valid and is also strong. So then we divided this genetic risk score into quintiles to examine its association with sleep apnea. So this analysis was conducted in those 3 Harvard cohorts based on self-reported sleep apnea. So you can see for the when we include all self-reported sleep apnea cases, actually we didn't see any association. So the association between the genetic risk score for CRP and sleep apnea risk are very known. But when we focus on the sleep apnea cases with sleepiness, you can see the sample size, the case number become much smaller. But when we focus on this OS subtype, we observe a positive association between the CRP genetic score and the sleep apnea cases with sleepiness. So this suggests that that the genetic risk score may be particularly relevant for those symptomatic sleep apnea cases. So then further, we did a one sample Mendelian randomization to confirm whether this association is causal or not. So for people who are not familiar with Mendelian randomization, so this is a kind of a causal approach that trying to kind of validate those observational associations. So basically, what we're interested in is the association between the exposure, which is CRP, and the outcome, which is sleep apnea. But this observational association is confounded by many many risk factors, so confounders. So to can account for those potential unmeasured or residual confounding, we're trying to use a genetic instrument. So it's G as a kind of surrogate for the exposure, and it evaluates the association between this genetic instrument and the outcome. Because this genetic instrument is unconfounded by those risk factors, so any observed association based on the genetic instrument is considered to be causal. So we did one sample Mendelian randomization in our cohort using the multivariable adjusted two-stage predictor substitution methods. So first we look at the association with all cases. So here, this is the estimates for the biomarker association that we published, which I just described in the prior slides. And this is the estimate from the Mendelian randomization. So you can see while there is a suggestion of positive association for the biomarker, the genetic evidence suggests there is no association. So this is based on model 1 without adjusting for BMI. So then in model 2, we see that the observation association was attenuated, but it was still significant. But still for the Mendelian randomization, there is no association with the genetic risk score. And then we did, I think, repeated the analysis for the OSA subtype with daytime sleepiness. So I think this, so now I think the pattern is very different. So you can see the estimates from the observational studies are very comparable to the estimate from the Mendelian randomization. In fact, I think the estimates are almost the same. And even after adjusting for BMI, the association for biomarkers, the biomarker association was attenuated. But for the Mendelian randomization, I think the association remained. I think one thing is that the genetic risk score is not associated with BMI, but for the circulating CRP, it's strongly associated with BMI. So after adjusting for BMI, we observe attenuation for the biomarker association, but the association from the genetic analysis remain unchanged. I think the results from the Mendelian randomization suggest that inflammation may be a causal risk factor for sleep apnea with sleepiness. But I think one question that remains unanswered is that whether it's only just related to sleepiness or it's related to that OSA subtype, the OSA with sleepiness. And also we don't know, because this is based on self-reported sleep apnea, and then we don't have measure for OSA severity. So we don't know whether it's just because the inflammation is more strongly associated with more severe sleep apnea that's characterized by the concurrent sleepiness. So I'm currently doing some additional analysis in MESA using the objectively measured sleep apnea and see whether we can answer those questions.
Can I ask a question here?
Yeah.
So another alternative might be that the sleepiness that is detected here is a cognitive inherent brain state.
Okay.
And so the inflammation peripherally can affect inflammation in the brain and produce sleepiness.
Okay.
Through those things. Are there any cognitive testing in that? I think there are cognitive testing in that cohort.
Yeah, there is in both in the Harvard cohort and also in MESA. Yeah, we can also examine that too. Yeah.
Because I think that this, from my, when you say inflammation, I now I'm thinking both peripheral as well as brain, and they're interrelated. And there's research here on whether pneumonia changes inflammatory mediators in the brainstem, and that direction has been shown.
Okay.
And then whether or not inflammation in the brain produces more sleep apnea, and that may be the Alzheimer's connection from some way.
Yeah. Okay.
And so that these are the. But I think this is really a very fascinating path analysis.
Yeah. And also, I think some limitation of the study I want to mention is first, we only focus on CRP. We know it's a non-specific inflammatory biomarker. So I think some future work should focus on some specific inflammatory biomarkers, like interleukin-6 or TNF-alpha, and to look at whether a specific inflammatory pathway is more relevant. I think, yeah.
Well, I've been down that road of biomarkers, and if you got CRP, I'd ride that horse. Because I don't know if you're going to find a lot of other things unless you kind of poke into things like bone marrow bone marrow cells that get mobilized to produce inflammatory responses as they do in sepsis or they do somewhere else.
Yeah, I think that's good point. I think another limitation is whether systemic information versus local information in the upper wing is more important. Yeah.
Because some of them are evanescent. And then the other is brain imaging that focuses on the effects of inflammation on brain, resting brain state and brainstem. There's really very few studies looking at brainstem MRI, functional MRI. I mean, it's possible, but the neurologists ignore that because it's they ignore the brainstem.
Okay. Okay, so I think then I did some similar analysis looking at some diabetes-related traits and sleep apnea. So I think, as I mentioned, I think although we observe association between diabetes and sleep apnea risk, we don't know whether it's insulin resistance or hyperglycemia play a role, or both play a role in the association. So in this analysis, first we look at the association between fasting insulin as a measure for insulin resistance and sleep apnea. And also we did this analysis in those all 4 cohorts. So we can see like in model 1, without adjusting for BMI and waist circumference, we see very strong positive association between fasting insulin and sleep apnea risk. And in model 2, when we further adjusted for those adiposity measures, we see attenuation in the association. But I think the association is still very strong and robust. And even in model 3, we include the HbA1c, which is the marker for hyperglycemia in the model. We see that the association remain unchanged. And then we did a similar analysis for HbA1c. And again, in model 2, there is strong positive association, which was attenuated after adjusting for adiposity measures in model 2. And in model 3, I think interesting when we're including fasting insulin in the model, I think the association with HbA1c is no longer significant. I think these results suggest that insulin resistance may be more important than hyperglycemia in promoting sleep apnea risk. And I think another interesting findings is that we utilize the objective measures sleep apnea in MESA, and we look at whether actually the association between insulin resistance and HbA1c with OSA severity. You can see we observe very clear linear dose response association between those 2 diabetes-related traits and OSA severity. And I think this dose response pattern, I think, provides some additional biological plausibility that insulin resistance and also hyperglycemia can promote sleep apnea. But like what's different from the inflammation is that, however, we didn't observe difference in the association by OSA subtypes, such as daytime sleepiness or airway collapsibility for the association with fasting insulin or HbA1c. Although we hypothesize that like insulin resistance particularly may increase sleep apnea by enhancing airway collapsibility. So there are some other supporting evidence for like the inflammation and insulin resistance as like the risk factor for sleep apnea. So we did some work look at some lifestyle factors, because we know lifestyle factors such as physical activity and sedentary behaviors plays very important role in modulating inflammation and insulin resistance. So this analysis was led by one of my students, Dr. Liu. So she she conducted a prospective study in our like 3 Harvard cohorts. And what we found is that higher level of recreational physical activity were significantly associated with lower incidence of sleep apnea. And this association remained even after we adjusting for BMI and waist circumference. So you can see, compare people with the highest level of physical compare with people with the lowest level of lowest level of physical activity. Those with the highest level, they have like more than half like reduced risk of sleep apnea. And similarly, we look at the association between sedentary hours in relation to sleep apnea. So for sedentary hour, we look at the two different types of sedentary behaviors. One is sitting, watching TV. We see that compared to people who sitting, watching TV for more than 28 hours per week versus those with less than 4 hours per week sitting, watching TV, we see that the hazard ratio is 1.78, like almost a 80% increased risk. And similarly, for sitting at work or away from home, we observe similar positive association. So there is an increased risk about like 50%. And I think another interesting finding is that even when we put these two like behavior in the same model, we still observe like significant association, suggesting that physical inactivity and sedentary behavior were independently associated with higher OSA incidence. I think another study like we are currently doing is look at diet association, doing some prospective study evaluating dietary patterns in relation to sleep apnea, because we know diet is also play a very important role in inflammation and insulin sensitivity. So we use the alternative healthy eating index as a measure for overall dietary quality. So higher HEI score indicates higher diet quality. So when we compare the like the risk of sleep apnea between those extreme quintile, we see that people with the most healthy diet have about like 20% reduced risk of sleep apnea. But after we adjust for BMI and waist circumference, this association remain like this association become non-significant. And then we look at another dietary pattern, which is called empirical dietary inflammatory pattern. So this dietary score, EDIP score, was developed against those inflammatory biomarkers. So this is a dietary pattern that is that is strongly correlated with circulating inflammatory biomarker and also systemic inflammation. And a higher EDIP score indicating higher dietary inflammatory potential. So when we do the same comparison for the extreme quintiles of EDIP, sorry, I think I forgot to change the result. I think the people have the highest inflammatory dietary pattern. I think they have almost 80% increased risk of sleep apnea. So this association is actually much stronger compared to the overall dietary quality. And I think I forgot to change this slide, is that the association actually for the empirical dietary inflammatory pattern remains significant even after we adjusting for BMI and waist circumference. So because of the difference between those two dietary patterns, we look further into the individual dietary components. So what we found is that I think although many of the dietary components are in the shows association in the direction like we hypothesized, I think intake of red and processed meat shows the most consistent and the strongest association. And also this is the dietary component that was included in both indices. And then we try to look at why those inflammatory dietary pattern was more strongly associated with sleep apnea risk. So what we found is that actually higher coffee consumption, which was included in the EDIP but not in HEI, was associated with lower sleep apnea risk. And we know that coffee and even caffeine in coffee is a strong antioxidant and also have strong anti-inflammatory effects. I think these studies on lifestyle factors provide some indirect evidence suggesting that inflammation and insulin resistance are important in sleep apnea prevention. So I think the final supporting evidence I want to mention is there are also some study look at some inflammation-related conditions, and they find also increased OSA risk among people with these conditions. So first is diabetes, which I can describe before, and also there are studies look at rheumatoid arthritis and asthma. I think they also observe increased risk among people with these inflammation-related conditions. I think the final part of my talk will be discuss some clinical implication of these findings. I think many of you know that there are I think multiple randomized controlled trials that evaluating whether CPAP treatment can reduce adverse cardiovascular outcome. But I think the results are not that encouraging. I think based on a meta-analysis of 10 randomized trials, I think the meta-analysis show that there's no significant benefit overall for CPAP on cardiovascular outcomes. And also, I think they didn't observe consistent reductions in CRP, insulin resistant, or triglycerides after CPAP treatment. Also, there are several randomized trials on CPAP treatment and glycemic control or insulin resistance among people with comorbid diabetes and sleep apnea. And again, I think based on meta-analysis of, I think 6 randomized trials, they found no strong effect overall of CPAP treatment on fasting glucose, fasting insulin, or HbA1c among people with diabetes and OSA. I think only one study, they reported moderate improvement in glycemic control and insulin resistance after 6 months of CPAP treatment. So as you can see, all these randomized trials, I think their rationale actually based on like the one direction of the association, which is sleep apnea can lead to adverse cardiometabolic disease. So I think based on like the findings I just presented for the other direction of the association. So I think the direct question is whether treating inflammation or treating insulin resistance can prevent or can improve sleep apnea. So first, I think I didn't find any studies that looking at whether anti-inflammatory treatments can reduce sleep apnea risk. And also there are several emerging studies evaluating whether diabetes treatments can reducing sleep apnea or reducing sleep apnea severity. So, for example, I think this is the study that's conducted by like the Case Western group. So they reported that in an exploratory RCT, they found that use of a sodium glucose co-transporter inhibitor is not only protective for those adverse cardiovascular and renal outcome, but also reduce risk of new onset sleep apnea. And also there is another small intervention study. They found that intensified anti-diabetic treatment over a 4-month period resulted in like favorable reductions in those sleep apnea related measures such as AHI or sleep time with oxygen saturation below 90%. And also these changes are not entirely due to concurrent weight change, suggesting that like treating insulin resistance or treating diabetes may have some like independent effect on sleep apnea. But I think not all studies found those encouraging results. For example, there's a pilot study, I think from a Stanford group. They found no changes in those polysomnographic sleep measures after improving insulin resistance using some pharmacological treatments. So I think the final piece of the clinical implication is so whether a lifestyle intervention should be like recommended for sleep apnea prevention and treatment. I think there has been some studies suggesting that lifestyle interventions are beneficial for effectively reducing OSA severity and excessive daytime sleepiness. And those lifestyle interventions including weight loss, exercise training, and the nutritional counseling. So like mainly following a low fat and low calorie diet. But I think there is no intervention study or randomized trial has evaluated whether lifestyle modification could reduce incidence of OSA, which this is like from OSA prevention like perspective. So in summary, Experimental studies provide, I think although limited, provide compelling evidence that inflammation and insulin resistance are important pathogenic mechanisms for OSA. And the prospective epidemiologic studies suggest that elevated inflammation and insulin resistance, even in the subclinical range, are associated with higher OSA risk. And more studies, such as those genetic-based Mendelian randomization, are needed to establish the causality of the observed association. And also larger intervention studies and randomized trials are needed to understand whether reducing inflammation and insulin resistance through pharmacologic treatment or through lifestyle modifications are effective in preventing and treating OSA. Yeah, so that's my talk, and I'd like to thank my mentors, Dr. Susan Redline, Dr. Mayor Stanford, and Dr. Shelley Roger for their support, and I would like to thank the grants that support my research, and also the participants and staff from the 4 cohorts that I use for my analysis for their valuable contributions. Yeah, thank you. I'm happy to take any questions.
That's terrific. So kind of people get to think when you do these cohorts for unexpected findings because they come out and give you some ideas. I think the exercise issue might actually be something that helps understand brain inflammation, because exercise itself, moderate exercise, can reduce connectivity and resting brain state, as well as response to dopamine eliciting maneuvers. So that's another kind of physiologic approach. But we have a bunch of people that that have some ideas. I have lots, but I can always defer.
I had a quick question. From the nurses study, when you pulled out those 9,000 patients who are self-reporting and then looked at their inflammatory markers, did you also select for other confounding conditions, or exclude those? How did you?
Yeah, so actually, for those biomarker analysis, I think the number of cases is not like 9,000 first. Only a subset of our participants have like those biomarker. I think about 10,000 participants have those biomarker, and among those people, there are about like 1,000 incidents like OSA diagnosis. So we, I think in analysis, I think we adjusted for some comorbidities like for example diabetes or hypertension or hypercholesterolemia. And also we did some analysis where we exclude people with those inflammation-related conditions like rheumatoid arthritis, or I think a few more conditions like, and also prevalent cardiovascular disease, because those people tend to have like elevated inflammation. And even when we exclude those people, we still see, I think, a significant association. I think another, let me see. I think another point I want to mention is, so you can see from the distribution of the fasting insulin level, you can see actually the majority of the the study sample, they actually have relatively I can't say normal, but relatively like healthy fasting insulin. So most people, they didn't reach like the cutoff for like the clinical cutoff for insulin resistance or for like diagnosing diabetes. I think a similar scenario for CRP. So you can see here like the value of the CRP across the the quintile. Yeah, you can see even for people with in the highest quintile, the median value in the highest quintile, like the CRP is only 5.5 like a milligram per liter. We know that clinically, like usually people think 10 like a unit or above will consider to be problematic or will need some like clinical attention. But you can see most of like the participants in our study, they have like subclinical elevated inflammation or insulin resistance. But even for this subclinical range, we still see like a strong positive association. Yeah.
So one of the reasons I like to think about children in OSA is because children don't carry all the baggage that adults do, and that the illness itself is telescoped pretty quickly into the the duration of sleep apnea, not as long as what we think happens in adults. Any particular insights from children's cohorts, or are there any, or do you expect to see some?
I don't know. So I think they're actually, so I don't work with the pediatric like populations. So I'm not sure if there are any like cohorts available for this kind of prospective analysis. But I know there are actually some meta-analysis. I think they mainly meta-analyzing those cross-sectional studies. I think they see similar findings in adults. Yeah, but those are cross-sectional findings. So we don't know like which direction of the association. Yeah.
Okay, Anna Mae, John?
No, I was just thinking, in terms of the brain and fMRI imaging, it's very difficult to image the brainstem with functional MRI. I mean, you need like a 7 Tesla magnet and have to be perfectly still to get good pictures. I mean, on the other side of the coin, I mean, I'm fascinated by the inflammation and brain function because you see it all the time in sepsis. The first thing that goes when you're septic is your mental status. So I keep seeing a lot of OSA patients that I fixed their sleep apnea, but they're still sleeping. I mean, it's a very frustrating situation. I'm not the only guy that runs into that, but I mean, is the next marker inflammation that we should look at to see why people are sleeping? I mean, it's, I'm just running through the possibilities, what am I missing? And maybe this was a great talk, by the way. And, is there some inflammatory marker we check to say, hey, you're sleeping because your brain's inflamed because of for whatever reason. I mean, if you're infected, it's obvious, but if you're not infected, I mean, it's less obvious.
So CRP is not for cardiovascular risk anymore.
Yeah, I agree. I think there are actually more evidence suggesting like the inflammation is important in like sleep physiology than the evidence like for sleep apnea. So I think there are actually multiple Nature review paper. They look at how inflammation play a role like in in regulating like sleep-wake balance and also those sleep propensity, those kind of things. Yeah, I think there are a lot of strong evidence there. But I think most of the also are based on experimental evidence. So in humans, I think the evidence is still limited. But I agree. Even I think for like my analysis where we see like the genetic risk score for CRP is associated with sleep apnea with daytime sleepiness. I think my like feeling is maybe this is just like the association with sleepiness. It's not the association with sleep apnea. Yeah. But I think I just need to do some additional analysis to figure that out. Yeah.
I have a question. And thank you, Dr. Huang, for a very wonderful talk this morning. So I know there's been some studies showing a relationship between sleep apnea, dementia, amyloid deposition. And starting with the question that you were trying to answer at the beginning of your talk, if inflammation and insulin resistance are predisposing factors for sleep apnea. So as we know, in type 2 diabetes, it's been well described that there's a deposition of amyloid in the islands of Langerhans, like the polypeptide amylin. I was thinking if you are aware, and since also amyloid could be like an acute phase protein reactant, if you are aware of any relationship between type 2 diabetes, deposits of amyloid, and the deposits of amyloid in upper airway, and by this I mean like larynx, tongue, so structures that could be implicated in sleep apnea. Thank you.
So I know like there is a link between diabetes and like cognitive functions, but I don't know about the literature on those specific like brain like markers, whether they have been linked to like diabetes or any diabetes related traits. So, but I think I think I mentioned like in the framework, I think all these things, I think like the relation is very complex, and many of the things they are in a bi-directional fashion. I think one thing is, for example, inflammation is also risk factor for diabetes. So if people the inflammation could lead to diabetes first, then lead to sleep apnea. And then these two can contribute to like a cognitive decline. And then like inflammation can also lead to sleep apnea first, maybe then lead to diabetes. And then those two lead to cognitive impairments. So I think, yeah, I think there is like a lot of possibilities, like how these things are related to each other, and they work together to lead to some adverse chronic outcomes.
Well, two other thoughts. One is in the data sets that are longitudinal, are there any examples in which diabetes is diagnosed after successful treatment for OSA? So it would be the idea that is, and it would be messy, the treatment, but people would have to say, yes, I have it. Yes, I'm on therapy. You might not be able to get how effective it is. But my impression from the work that we did on biomarkers in the 90s was that and we had, these were not published, but we measured insulin levels and glucose levels and treated sleep apnea patients. It took 18 to 24 months for the insulin levels to start to drop. And, by that time, they had gone through this weight gain and then sort of settled down again. So it may take a long time for things to get better. And the other is that, right now we've been talking about whether or not sleep apnea could lead to diabetes. And I don't think that's true. I think that diabetes is a fairly well conceived human illness that has both genetic and evolutionary backgrounds that then collides with something called upper airway instability, which is somewhat uniquely present in humans.
Yeah.
That then interacts with those things. So that's what our thinking is here.
Yeah, I agree. I feel like I think the strongest thing is obesity. So
Yeah.
because we know, I think,
well,
you can see many analysis.
It's obesity is a big, obesity and inflammation are so big. I sometimes it's hard to wrap your head around it.
Yeah, it's hard to tease out whether it's obesity, like those mechanical effects, or it's those in biochemical effect, like inflammation or insulin resistance, resulting from obesity.
Yeah,
I think, it's very hard to tell.